So welcome to the clinic.
Thank you.
Gabriella, lovely to have you here. Today we're talking about injectable treatments, particularly filler injection treatments. So maybe can we start off with a bit about yourself and what you had in mind?
Yeah, so my name is Gabriella. I am a hypnotherapist. The treatments I've had in the past have been rhinoplasticity and a bit of lip filler. I had a bit of Botox as well. But today I want to do my lips, and I was thinking about maybe having a bit of under eyes, filler in the under eyes, and whatever else you may suggest.
Perfect. So we had a good chat off camera. We just for everyone to understand, we've spoken about medical history. We've gone through the consent process. We've covered all the risks off. So I just want to kind of fast forward to the bit where we're doing a facial assessment so we can agree on a plan.
Yes.
The two main things you spoke to me about were the nose and the lips.
Yes.
And why would you say those are your priorities?
I think that I know that we're not all, what's the word?
Symmetrical.
Symmetrical, that's the word. But I think it's very noticeable in that one side of my nose is very kind of bumpy and got contours. The other is more straight. So I want to create balance. Also as well, my top lip is considerably small. Well, I feel is a lot thinner than my bottom lip. So I want to create balance as well. And more of a natural look. But yeah, just to create some symmetry.
Okay, got it. So what I'm going to do is I'll go through everything and I'll tell you what I see. And then if you're happy, we'll do that plan. Okay.
Sorry to interrupt this video. Hi, I'm Dr. Tristan Mehta, founder and CEO of Harley Academy, and I'm the one doing the injection that you're watching right now. I just want to take a moment to talk about our injectables diploma. So Harley Academy is a higher education college for aesthetic medicine based out of the centre of London, UK. And over 3,000 medical professionals have gone through our academic programs to achieve a postgraduate diploma in aesthetics. They will get a title after their name, PG Dip Aesthetics. If you want to learn more about our programs, how you can gain your qualification and learn how to inject in a really structured, systematic and evidence-based way, then click on the details below and our team will be happy to have a conversation with you. Right, that's enough from me. Let's get back to the video. But if you are enjoying this and you want to see more content like this, please subscribe and click like.
Let's talk about the face and what we see in thirds. So upper third is hairline to the glabella, middle third is glabella to the base of the nose, and then this is the lower third. So we've got equal vertical thirds. Anything that stands out, well, first of all, I think she's got very good radiant skin condition. I think she's got excellent symmetry in the upper third. I think the nose is where we start to lose a little bit of symmetry in the mid face. And then we have a very balanced lower face as well. And you can see this on profile in that all of these features have equal amounts projection, and also where it's appropriate, we have no projection. And so you can see the chin, then we have the crease, we have the lips, we have the nasolabial angle, we have the projected nose. We don't have a significant dorsal hump, and then we have a nice rounded youthful convexity to the upper face as well. So I'm actually reasonably happy with the face. I'm very happy with the face on lateral view. I think a lot of our opportunities are in subtle enhancements to various facial regions as we go through the face systematically. So upper face, brow, excellent. Temples, we have a general volume loss, and in your early 40s, you're going to start to see some volume loss to these characteristic areas, and temples is definitely one of them. So we can look at treating the temple. I also then see in the midface we have this beautiful cheekbone, but I can imagine that if we enhance this a little, it would be even more striking, and that's going to be quite important if we're going to also add volume to the temples and then the area beneath the temple as well, the lateral cheek fat. So there's definitely a sequence here that's the temples, the lateral midface and the medial midface, which together would look really, really nice. You notice around the eyes, we don't have any supraorbital hollowing. There's no indication to treat above the eye, but if you look upwards for me, chin down a little, you can see here that there's some shadows under the eye which would respond very, very well to tear trough treatment. So I think that's definitely a great indication. back to the midline now. And here we have some irregularity to the dorsum of the nose. I can feel this. Gabriella doesn't talk about much of in the way of history of any trauma to the nose, but I can certainly feel there's some irregularity to the bony surface of the nose. And so some filler to try and override that and create a narrow, very smooth dorsum to the nose would be very aesthetically important in this case. We can also consider just creating a little bit of elevation to the cartilaginous aspect of the nose, which will, I think, ever so slightly improve the aesthetic, particularly on profile. If you notice that the nose, the tip of the nose starts to point downwards, and we can instead get it to be pointing more forwards. So that's how I would assess the upper and the middle third. If we take a look at the lower third in isolation, one of the first things I notice is actually we have a relatively elongated upper lip. And in female patients, ideally we would have 1/3 upper lip, 2/3 lower lip, 1/3 upper lip and 2/3 this lower portion of the stomian to the menton. And so what I see is that if we can create some vertical height in the upper lip, we're going to narrow this gap. And in the process, we're actually going to feminize the lower third. I think the upper third is very feminine. I think that the middle third is very feminine with these beautiful cheekbones. And then the lower third has the possibility of becoming even more striking and beautiful if we manage these proportions. And so that means increasing the vertical height of the top lip. And at the same time, I noticed that if we create a little bit of projection at the apex of the chin, pointing in this inferior direction, if we turn all the way this way, we can see that if we create a little bit of projection like this, it would also be a really nice feature as we have continuity from the gonial angle all the way down to the anterior aspect of the chin. I don't think we need to do any treatments at the corner of the jaw or the mandibular border, which for me are all really in fantastic condition. So in summary, this is a full face treatment using filler in lots of different depths, lots of different areas. But how do we decide what to do first and how to sequence things? Well, first of all, following our principles, we're going to start from the top of the face and work our way down. We're going to start from the lateral cheek or the lateral face and work our way medial. And we're going to start deep and we're going to work our way superficial. And so following that algorithm, that gives us a sequence for how to treat the face, and it will start with the temples and it will finish with the lips. Does that sound good? Mm-hmm. All right, then let's get started.
Thank you.
So let's start off with the temples. How do we decide which type of technique to use for the temples? Well, each of them have a different effect. If I was really focused on lifting the tail of the brow, I'd be thinking about any treatment that goes underneath layer 3 of the temple, for example, the interfacial technique or the periosteal technique. If I had a broad, diffuse area of volume loss that I wanted to treat, I would be thinking about the subdermal technique. In this case, what I'm really interested in doing is treating a mid-sized area of diffuse volume loss and also supporting the tail of the brow, and of course also creating some support in the midface. And so to do that, the ideal technique is the interfacial technique. And I'm going to demonstrate that on this patient. We start off by identifying the temporal crest and in addition the lateral orbital margin. And then I also identify the superior border of the zygomatic arch. This gives us the visible portion of the temporal fossa in the anterior to the hairline. And my approach is to actually enter the interfacial space from the forehead because the plane underneath the frontalis muscle is continuous with layer 4 in the temple. This is a good chance for us to recap what exactly is going on in the temples in terms of anatomy and vascular risk. So first of all, I'm going to palpate for the superficial temporal artery. Usually we just find it pulsating anterior to the tragus. I can feel that here. And then we can follow this along. I can palpate it here. And really, I'd be really interested to know whether we have the artery within our injection plane. And we don't. So the artery in this case is fortunately staying within the hairline. So I'm not concerned about the superficial temporal artery. The reason I picked that up is not because I'm actually in the same depth as that, but because it's always important to know where that artery is for any injection we do in this area, as it actually has anastomoses with the internal circulation. And that means that it does carry some of the significant risks that we are concerned about with filler treatments. But if we go through the layers, we've got the skin, we've got the subcutaneous fat, a small amount of subcutaneous fat. Then we have layer 3, which is the superficial temporal fascia. That's continuous from the frontalis up here to the SMAS of the midface and the orbicularis oculi muscle. And it's actually within that superficial temporal fascia that the superficial temporal artery lives. It lives between a sandwich of two fascial planes of layer 3, and that's where the artery lives. Underneath the superficial temporal fascia here is our interfascial space. And the reason it's called the interfascial space is because it exists between the superficial fascia and the deep temporal fascia. And this is a plane that's suitable for injection because it does not contain any arteries. So that's why it's considered one of the suitable injection depths for treating the temples. But importantly, it's deep to layer 3. And because it's deep to layer 3, it allows us to have some of these benefits of creating tension across the brow and across the midface. But also, importantly, it's a plane which does not have an artery. It does, however, have two important structures. One is the facial nerve, and number 2 is the sentinel vein. So there is a vein that lives in layer 4 as well, and that vein is draining from the supraorbital vein down into something called the middle temporal vein, which is much deeper in the temple. And so when we're injecting in this interfascial plane, we have to still be careful because we could lacerate that vein and it could cause a deep and painful hematoma, and we don't want to do that. So I'm still going to be injecting carefully, but I'm conscious that I'm deep to the superficial temporal artery in layer 4. So with that in mind, I'm going to be using a 22 gauge cannula, and I'm using a projecting filler, in this case, Revenes Contour. And I stand on this side whilst I'm injecting because it's very comfortable for me to do that. I'm just going to lower a little bit. So let's make our entry points. Now normally I'm very clear that the cannula entry point doesn't need to go any deeper than the skin. But in this case, this is one of the few injections where I need to take the cannula all the way down to the frontal bone because I'm deliberately trying to go into this space that's deep to the muscle. From here, we pass through the skin, through the frontalis, and now over the temporal crest, and you will find yourself into this depth. This depth looks like it's under the skin, but it's underneath under the muscle in the frontalis and underneath the superficial temporal fascia in the temple. This plane, this interfascial plane, is normally closed, and so it can be quite tight. And so what I'm injecting here is with a gentle anterograde and retrograde movement, fanning into the interfascial space. And this is my slow, controlled movement so as not to cause any laceration or trauma to any structures that I will find in this depth.
Am I right in thinking that layer 4 in the forehead, that subgaleal plane, is the same as that interfascial plane in the temple? So once you get down through the frontalis muscle, you know you're in that glide plane straight into the interfascial plane.
Yeah, exactly right, Max. And if we therefore use the forehead as a way to drop into this depth, it's far more reliable. I have previously treated from beneath, but you're struggling to find that surface that allows you to know that you're in that same depth.
Yeah.
So here we have half a syringe into layer 4 in the temple.
Instant, isn't it?
Any pain at all?
No.
All right, so now the thing we're going to be always interested to see after a temple treatment is whether or not we get some nice improvements to the tail of the brow, the corner of the eye, but also the midface and sometimes the corner of the mouth. So let's just, if I say look into that camera coming off the ceiling, sit forwards for us. Beautiful, okay. So I hope we can appreciate here that we have a good elevation to the brow, but also this eye. If you look at the lateral canthus of the eye, notice that it's a little bit higher up on this side. Maybe you can also see a little bit of lift to the jawline as well, as we've started to create this tension and projection in this direction. So this is the power of the temple treatment, is you can improve the face in all of these different dimensions. Same on the other side now. Just palpate for the superficial temporal artery. See if we do. Okay, I have a pulsation here this time. Okay, so I can feel this. This superficial temporal artery is right in the middle of my temporal fossa that I'm trying to treat, and it is then moving superiorly up the forehead, and I can feel it here. This is important because I'm not going to inject, I'm not going to make my entry point here, I'm going to be beneath it. So here I can say that my entry point is beneath the superficial temporal artery as I make my bony contact, and we just give it a few seconds. Okay, great. And then we drop behind the frontalis muscle into layer 4. And now I can slowly advance beyond the temporal crest. There. So here, I've just got my finger here on the superficial temporal artery still, so I've just got my landmarks, and I've got anterograde pressure as I open up this space.
It's really normal to see. I wonder whether it is a little bit of compression of the sentinel vein. Some, particularly the venous structures, are popping up a little bit.
Yes,
on the surface, but I'd say 9 times out of 10 that settles down within a couple of hours, and almost always by the next day.
Yes, absolutely right. That's somehow we're increasing the venous pressure, and we do see these surface veins pop out more after temple filler treatments. We can be very slow and gentle in this area. That's done. Now let's take a look at the entire temples. If you look back into the camera, head off the bed a bit. Perfect. Now, I'm already happy with that. Can you see that? Mm-hmm. See a little bit of refreshing going on?
Yes.
All right, good. Now rest your head back. Now we're going to start talking about the midface. I told you briefly my thoughts and my strategy. The first thing I want to find is the apex of the cheek. So I grab the lateral orbital bone and I find halfway on the bone between my 2 fingers. So that's my lateral orbital bone. I'm there. And then I think about this dropping vertically down the face. From here, I don't really often draw this horizontal line. I just have a look from the front and I think, where would the most beautiful apex of the cheek live in this scenario? So you've got these 2 vertical lines now. So head off the bed, looking into the camera. And the way I see it, I would want to create projection around here. I think this would be where I would want to create a really nice, feminine, beautiful apex of the cheek towards this way. Same around here. So this gives me my landmarks for where I want to create lift. And if we follow the zygomatic bone backwards, rest back, I like to draw on the underside and really palpate these bony landmarks, because ultimately a natural cheek will follow the underlying bone. And so this is my cheekbone. The same on this side. Just press, okay, and you will feel where the cheekbone lives yourself. So here we have an idea of where I will create my projection and where I want to create my lateral definition as well. Sit forwards. So the idea here is that we're going to create some projection of the apex, and then we're going to tail it off laterally, and we'll do this on each side. And this is now an important time to talk about an important structure in the midface, which is called the line of ligaments. If you think about the gem and how we're structuring each zone of the face, we have a key concept, and those key concepts are things that we think you should know or have some education about before starting to inject. And one of the key things in the medial midface, in the lateral midface, is our line of ligaments. And so I'm going to reference this now. So we have a zygomatic cutaneous ligament here. We have a lateral orbital thickening here, which is the insertion, the origin of the orbicularis retaining ligament. We have this temporal adhesion here, and we have this mandibular ligament here. And so if you follow a line that connects each of these structures, so this is the temporal adhesion, temporal ligamentous adhesion, where basically the temple is all adhered to the skin, the fascial planes. We then have the lateral orbital thickening. We have the zygomatic cutaneous ligament, and we have the mandibular ligament. This line divides the midface into the medial midface and the lateral midface. And the reason that's important is because this is non-mobile and this is mobile. So if I put my finger here and give me a really big smile, my finger moves upwards. Relax. Smile again and relax. The reason is we have lip elevators here that all insert into the prominence of the zygoma, for example. And so this isn't medial to the line of ligaments and it's mobile. If you smile now and relax, my finger doesn't move and it doesn't even feel any motion underneath it. And that's because we are in the so-called fixed midface. And what this means is that generally when we're injecting this side of the line of ligaments, it's okay to be superficial. It's okay to be injecting just underneath the skin if we want to create some definition like this, or in the preauricular area. And it's okay because when the patient smiles and expresses, it's not going to move around. But if you inject medial and you start to inject superficially too much, and give me a big smile, you will start to see movement and unnatural flow of facial dynamics with the filler. And so the line of ligaments tells us two things. First of all, that we can inject superficially if we want to. Okay, we can also be deep here if we want to create deep structure, but also that we have to be careful about injecting superficially medial to it. The second thing is that there's been a study which shows that if we first of all inject laterally, it means that we actually need less volume medially further down the line. And so that's why we say when we're injecting, we start lateral and move medial. So how am I going to treat the midface in this scenario? I'm going to combine those concepts into a strategy, which means that I'm going to treat the apex deep, okay? Because this part of the apex, we have the deeper fat compartments, the SUF, and also the pre-periosteal fats. And then I'm going to tail my cannula treatment off laterally, superficially, and that should give us a nice enhancement to the apex and the tail of the zygoma. Let's do some cleaning. And if we can have now another mil of Revenes contour. Mm-hmm. And maybe Max, do you want to talk about, because we've got two different types of, I'm going to do a cannula treatment for the apex and the zygoma.
Yeah.
And obviously we can be in different depths in the cheek, right? And this time I want to show the deepest plane and how we inject that with a cannula.
Yeah. So in that deep plane, particularly in this more mobile area, anterior to the line of ligaments, it's actually quite difficult to differentiate between true being in the souff and being in that pre-periosteal pain in that, what is also known as the prezygomatic space, or that fatty layer just underneath the pre-periosteal space. Actually, clinically, I don't know what you think, Tristan, I don't think, when you're with the cannula, it makes a huge amount of difference clinically. When we come more medially for a tear trough treatment, I think then it makes more of a difference what layer we're skirting in. But in terms of adding projection on the apex of the cheek, I think the language is more about the technique. So when you're with a cannula and you pop through either the SMAS or orbicularis oculi and then flatten out straight away, we call that souff. But then if you're coming down with a needle, particularly if you're coming in at an angle with that needle so that your bevel is facing down, then technically that's more the pre-periosteal fat.
Absolutely right. So that with a needle is how we are going to be able to differentiate between those targets. And Max is completely right in that clinically, whether I treat it in the souff or in the pre-periosteal fat with a cannula, it's hard to say how much we would notice. In this case, though, I do want to illustrate the difference between those different depths. And I'm going to do this through an entry point facing towards the tail of the zygoma, the zygomatic arch. Little scratch. Good. Okay. And let's talk about these depths that Max has just talked us through. So we go through the skin. We're in the subcutaneous fat. We see some tethering there. This is layer 3 of the face. And we go underneath layer 3. You'll see a pop there. This is now in the souff. And this is an important target which loses volume with aging. However, there is another layer, and you will feel another depth you can go into. This is the surface of the prezygomatic space. And this surface is another fascial plane that comes down from the temple and is a midfacial extension of the superficial lamina of the deep temporal fascia. And we can inject again in a deeper depth, even still. Now, there, it's just gone. And so here now, I am in the pre-periosteal fat. This is truly gliding onto bone. And in this depth, we can create very deep projection. Particularly in patients where they have malar edema, this would be a really important way to learn how to inject the cheek apex, if you wanted to at all. And I'm just injecting 0.3 mils of Revenous contour down into this deepest depths where I think I want to create my apex of the cheek.
I think as a general rule of thumb, it should always feel smooth, that glide plane. Unless you're subcutaneous and trying to do a more superficial treatment, when you're in any of those deeper spaces, you don't feel that resistance. And if you do feel that resistance, you're probably in between layers. You're injecting into the SMAS or into the muscle, and then just take a moment and find your depth again.
Yep, agreed. Now, this is now relevant for our line of ligaments. I'm coming back into the subcutaneous plane, and this is the depth now that I want to do the rest of the treatment. I don't want to stay deep. I don't need to stay deep. I actually want to create some surface change to the zygomatic arch, and I can do this by tracking my cannula in the subcutaneous plane through the same entry points and following the bone. So if I now move all the way back here, I can inject just a touch, a hint of definition to make this look even more feminine and elevated at the lateral zygoma, noticing that this will not move on expression because we are lateral to the line of ligaments. So in combination, deep projected apex, but superficial zygomatic arch, in combination give this very, very natural appearance to the cheek. And let's take a look. If you lift your head off the couch, look into the
Very nice.
camera, and that's really, really changed, I think, from one side to this side, which is quite a dramatic shift to the contour of the cheekbone itself. Head up. Straighten. Yeah.
And even the nasolabial folds, they weren't much of a concern. It seems they weren't that deep before, but now they're even more shallow.
Perfect. So I'm going to get that side, the other side done now. Good. So I take my markings off because I can appreciate where I would like to identify the apex of the cheek, and I can feel where I want the lateral zygoma to be, but there's no harm in drawing on the structures again if you needed to. So let's try this, let's demonstrate this one more time. We're in the subcutaneous fats. We're going to push through layer 3 now, sometimes with a little help. If you're using a larger cannula, like a 22 gauge, it's more blunt, and so it's a little more challenging to push through some of these layers. Okay, so that's in the souff. And then there's a second perforation. There. Mm-hmm. And now we are truly gliding onto the pre-periosteal fat. And I'm going to inject 0.3 in this deepest plane of the midface.
And the reason we're using a 22 gauge cannula rather than a 25 gauge or even smaller is purely safety. We're always balancing the size of the cannula to the safety of the treatment, the risk of going in a vessel, with patient comfort. And certainly in the midface, which is overall a comfortable treatment anyway, a 22 gauge cannula is very comfortable and also very safe.
Yep, absolutely agreed. On the way out now, staying in the subcutaneous plane and then finishing off my treatment in this layer 2, following the bony zygomatic arch that I feel between my fingers, and creating this surface level definition to enhance that lateral projection, give that very feminine contour to the lateral zygoma. Great. You're doing really, really well. Gabriella, how are you doing?
Yeah, not bad, thank you.
Okay. What we don't want to do is flatten this really nice deep projection. So what we can do is we can use a rolling motion like this just to help shape the underside of the filler. I don't want to squash this lovely deep projection that we've created. So by doing this, we can create even more enhancements. So take a look now. Now we're getting somewhere, aren't we? The next thing we're going to treat is the tear trough, okay? And the tear trough, if we just remind ourselves of the important anatomy here, we have the origin of the orbicularis retaining ligament identified by this bony margin. Okay, this is our superior aspect of any treatment that we're going to do in the midface. And then look at the limbus, the medial limbus of the iris. I like to draw a little arc coming down from here, which then denotes the zygomatic cutaneous ligaments. And the tear trough is a really important structure for us to appreciate anatomically. If you come off the bed a little, I want injectors to appreciate the difference between this line here, okay? This line here is not a tear trough. This is something called the nasojugal groove, and it's formed at the superior pole of this nasolabial fat pad. And so patients will have a groove here as a natural endpoint of the fat cushion that lives here. And that's often confused for a tear trough. If injectors try and fill this little groove, they will actually end up making the under eye worse. What they need to appreciate is the actual tear trough is the gap between this nasojugal groove and this ligament as it inserts medially called the tear trough ligament, which is part of the orbicularis retaining ligament. And so we're injecting into this very tiny space. The tear trough is between those two lines. In this compartment, technically, we're in the souph. But as we start to age, the fat pads drop off the zygoma and we reveal the bony surface underneath. And that's why we get this area called the palpebromalar groove, which is treatable with filler as well. But we're not here, actually, the souph, as we age, slides down like this. And so we've exposed this bony margin, which is our palpebromalar groove, which we can also treat with filler. But technically, this is not tear trough filler. Only this here is the tear trough. So I'm going to treat all of that today with Revenes Revise. Make a little entry point at the intersection between the subnasal line and the lateral canthus. That gives us a nice entry point here. From this entry point, we can navigate subcutaneous. Just open your eyes for us, look upwards if you can. See that dimpling? We're just going to push through there. Now we're in layer 4. Well done. And we can just appreciate where the tip of our cannula is. This is the depth it looks like when you're in the right depth. Okay, you can't see the outline of the cannula really clearly. That would be too superficial. And I'm doing little micro aliquots to smooth the transition. Note that there isn't a significant hollowing.
Yeah.
So this is just a blending type approach.
I often find in the under eye area, just really small changes make quite a big difference, because when you're having a conversation with someone, it's your eyes that they're looking at, and really subtle improvements just make you look more refreshed, more awake. I even find that people will respond differently to you if the eyes are treated well.
Perfect. So that is now all I would want to do, just to blend that lid to cheek transition. But I've obviously got this groove more laterally that I want to restore volume into. And to do that, we're just going to make an entry point overlying the zygoma. Laterally, the orbicularis retaining ligament becomes multiple lamina of connective tissue, and there are little fat divisions between those lamina, and so this is treating technically an anatomical target called the interlaminar fat, or the intralaminar fat. And We're going to again get to the right depth, little pop, and I'm treating now the groove. This is sensitive. If I go too far towards the eye, the patient will tell me, because I've noticed that in this area, if you inadvertently push up against the ligaments, it's uncomfortable. Total of 0.3 has been used. Every time I'm going in, I'm doing a tiny micro droplet of product. That's it. That's all I want to do for the infraorbital region. But let's take a look if you sit forwards. Lovely. So we can really start to see the blending, very youthful transitions that are appearing under the eye. Can you see? Are you happy?
Yes, I am.
Okay, let's do this side as well. So what do you think common mistakes people make with the under eyes are, Max?
Probably overfilling.
Yeah, yeah, I agree.
Often a result that looks fantastic on the day
Yes.
is a little bit overfilled, because as that hyaluronic acid draws water towards it, even in products that, say they don't swell, you're always going to get a little bit of that hydrophilic, hydroscopic response to it, and then a couple of weeks later, you're a bit puffy. So
Yeah, it's always, you've got to give it room to swell and attract that water. So we always undertreat.
And also understanding that it's normal to have a little bit of a transition between the cheek and the lid. Nobody, even kids, aren't completely smooth there.
Absolutely.
We're just looking to soften that slightly so that it's a bit less jarring, not eliminate it completely.
Agreed. There's also various factors that can complicate the tear trough, and we outline this in the infraorbital section of our GEM framework, but there are complex presentations that beginner injectors might think there is something that's treatable when it's not. For example, if there's lots of pigmentation under the eye, that's not a volumetric problem necessarily. It can't be significantly improved. If there's associated malar edema, if there are significant eye bags or pseudo prolapses of the intraorbital fat, all of these things can make presentation more complex.
That being said, if someone does have concurrent hyperpigmentation with true hollowing, then actually sometimes by improving that hollowing and improving the light reflex under the eye, even though you're not doing anything directly for the pigmentation, it can still make the under eye area look brighter.
Yeah.
But you need to examine, try and take that pigmentation out of the picture completely and examine the hollowing for what it is. A useful question I find is if a patient can put under eye makeup on or under eye concealer on, and that solves all of their problems, it's almost always either going to be pigmentation or thinning of the skin and seeing that muscle shining through. If even with makeup on you see a little bit of hollowing, then filler really is the only thing that's going to get on top of that from a non-surgical point of view. Lovely.
Perfect. Okay, final treatment in the midface sequence is going to be to just create some volume in this lateral cheek, this preauricular area, which is not only going to support the lower face, but it's also going to help some of the transitions of the hills and the valleys across the lateral face. I'm conscious I don't want to remove or reduce this beautiful new contour across the cheekbone, but you will see that it doesn't really change a huge amount of the surface level volume. It's more of the structuring effect it can have. So turn this way. So I'm going to fan some product in now. So we're learning a lot about depth control here, and maybe you could talk a bit about what we see on ultrasound studies in relation to filler going too deep in this region, Max.
Yeah, so underneath this whole area here, we've got the parotid gland. And it's really important to be able to always see the outline of your cannula and know that you're subcutaneous. This is the opposite of what I said earlier with those deeper fat pads, where if you're in them, you tend to glide smoothly. Here, you are going to feel that resistance, and that's fine. But always make sure, as you can see now,
Yes.
yeah, that the cannula is nice and clear. Because what we do often see is, not necessarily with patients reporting any problems, but when we're scanning faces, we're seeing that there is filler material, even from years ago, sitting within the parotid gland and within the overlying fascia as well.
Yes. So how can we, so I think one of the things that I read is sudden loss of resistance is a warning sign.
Yeah.
Doing great. So that's that side done. Okay, so this is a really good one to see on camera, because hopefully what we'll notice is that we haven't changed that lovely projection of the cheekbone. But what we have done is look at the jawline on this side and look how much we've managed to lift it just with 0.5 ml of filler. It's now no longer, it's more tapered. Okay,
Definitely.
if we look at where the weight of it is here compared to where it is here.
Very nice.
So let's do the same on this side. Head back, all the way this way. Thank you. How are you finding this treatment, Gabriella?
Yeah, not bad.
It often looks more uncomfortable than it feels.
Yeah.
You do feel it in your ear a little bit.
Have you got someone at home that's going to notice what you've had done, or?
Well, my daughter, but I doubt she'll notice because children never do they?
Well, they can be quite brutal sometimes, can't they?
Indeed, yeah.
So, to Max's point, you'll notice when my cannula, I feel like I'm going a little too deep, I'm always going to come back to this point where I can make sure that I'm in that subcutaneous, subdermal depth. And when I want to change direction, I'm almost having to come out completely. A big mistake people make is trying to change direction when they're already halfway in, and then they're just making more and more tracks down the same pathway.
But what you're not doing, Tristan, is injecting all along that pathway. Otherwise, you'd end up with that
Exactly.
big collection of filler right by the entry point.
So I stop injecting here.
Yeah.
And this will get some treatment, but I'm not repeatedly treating the same path over and over again. And that prevents nodules.
One thing I see quite commonly with trainees is almost being a little bit too delicate in this area. You do need, particularly with a 22 gauge cannula, a bit of force to get through those little adhesions and to subside them. And to get all the way back to the ear, it's often more comfortable to use a little bit more pressure than you think.
Right then, so this is our midface and under eye and temples all done, okay? I'm really happy with that result.
What we learnt in aesthetic medicine even 1 or 2 years ago is now outdated. Why? Because aesthetics is still a relatively new science, and the research underpinning our work, particularly our understanding of anatomy, has advanced significantly. Hello, I'm Dr. Tristan Mehta, founder and CEO of Harley Academy, and I want to introduce you to GEM, the Global Evidence Matrix. GEM is a dynamic, evidence-based framework that gives injectors a clear, consistent guide for safe, effective treatments. all grounded in science, not in corporate sales pitches. GEM combines clinical research, anatomical knowledge, and injector expertise, and it's always updated with the latest evidence. Think of GEM as your interactive map for facial aesthetics, guiding you through every step from technique to product choice. With GEM, you're not just injecting, you're working at the forefront of medical aesthetics. Join us in setting a new standard for safety and results.
Now let's take a look at the nose. We can see there are some irregularities to even the frontal view, where we can see a little bit of irregularity here, a little irregularity there. So these things are important when we consider something called the light reflex, which is the way in which the light bounces off the nose on frontal view. If we then turn all the way to the side, as we've said before, there is a dorsal curvature and a slightly drooping tip, and we have a dorsal hump and then an area here which we can add volume to straighten the nose. We've always got to be very careful to consent the patient appropriately for nose filler treatments, because as we know, the vascular supply is particularly high risk relative to other zones of the face, and I'm going to take a moment to explain that with a summary of the vasculature to the nose. So here we have our supraorbital foramen, and we have our supraorbital and supratrochlear arteries emerging in the forehead. We know that these are branches of the internal carotid circulation, also particularly in this scenario, the ophthalmic artery. So the ophthalmic artery is a branch of the internal carotid circulation that has a vessel that supplies the retina called the central retinal artery. The nose has a vascular supply from three major directions. We have the ophthalmic artery, the branch of the ophthalmic artery, which is the dorsal nasal artery. So that's coming down in the same way that we have these vessels, and this is our crucial connection with the internal carotid circulation. We then have the facial artery coming up, which is then becoming the angular artery towards the nose, and the angular artery has an anastomosis here with the internal circulation, in some cases called the alar artery, which is where we get connection from the external to the internal carotid circulation. So this is not always present, but when it is, of course, we do have a direct connection from the external to the internal carotid. We also have our infraorbital artery deep down here, and there are some branches, some medial branches that come deep from the infraorbital artery to connect up with the nose circulation. And remember, we also have the superior labial artery, which then gives rise to the columellar arteries, which run just under the skin up the columella. And because of this complex vascular supply, we have an unpredictable location for the vessels, and we want to be very cautious in terms of how we're injecting. And so that means that we have some rules to follow when we're injecting the nose, but the most important rule to follow is that we're always going to be consenting our patients appropriately, and if we can avoid injecting, even better. If we are going to inject, we've got to do it in the safest way possible. And for me, that includes using a cannula where possible, and if not using a cannula, then we're using a needle in the right places, in the right depths, and also aspirating. So I'm going to show you how I would approach this with a cannula, treating the dorsum of the nose and also lifting the cartilages at the tip of the nose to create some definition at the tip. We'll start off by drawing on these aesthetic lines. So if you rest your head back, we're going to follow the brow all the way down to the tip. And these lines contain where we want the definition of the nose to exist. Any interruptions to these lines is what will start to grab attention when we're looking at the nose, particularly from a frontal view. These lines connect the medial head of the brow all the way down to where we want the tip of the nose to be. So now I've got those lines, it's even easier for me to stand at the top of the bed, chin up, and see where we do have little irregularities, for example here, or here, or here. All of these are areas where if we're going to use filler, we can just help to create even more balance. Turn your head this way. So this gives me an idea of how I would treat the dorsum of the nose. Separately, I see that the tip is slightly drooping and I want to create a little area here where I want to create some new definition for the tip of the nose. And to do that, I'm going to have to treat both the columella and give a little bit of a filler deposit right here. The final thing to say is the bottom third of the nose has no layers. We're just skin, fibro-fatty tissue, and then cartilage. And then the upper 70% of the nose, we have our 5 concentric layers where we want to be injecting into layer 4 in the nose because the blood supply runs more often than not superficially. So the right depth to inject is in layer 4 in the upper 70% of the nose. And then in the tip of the nose and the cartilaginous nose, we just have to be careful to be injecting in the safest way possible. The columellar arteries are running just under the skin, so I'm going to be deep against cartilage for the columella, and again the same onto the perichondrium to create that nose tip. So let's get started with my lidocaine. The lidocaine gives me my comfort for treating for injecting the cannula entry point. The entry point is just where the nose drops off. So little scratch, a little sharp bit. This is the sharpest bit, okay? So just bear with me, Gabriella. I know this is going to make you sneeze. Okay. But once I've done this, it all gets better. Okay. Now, the cartilage of the nose and the bone of the nose are, of course, firm, hard structures, and that tells me the kind of product that I want to use, which is in this case a projecting high G prime product. That's Revanesse shape. And I'm going to start off with the tip of the nose, and then I'm going to work my way up the dorsum. So I've got my 25 gauge cannula here, and my entry point just facing where I want to go. But remember, I'm also going to have to go downwards as well. So I leave that in there for a few seconds to make sure I haven't cannulated anything. The nose is highly vascular, and so we can expect this to happen when we make our entry point. The blood supply comes from the side, and so if we squeeze from the sides, the blood stops. Okay, so we're in position. Passing the cannula down against the cartilage, down the columella. Can be a bit sore, well done. Touch down. And here we're going to now give a strip of product to really give support to the base of the nose. Fantastic. Whilst I'm here, I'm also going to give some definition to this tip here. Remember that there are no layers in this part of the nose, so I'm really injecting into this fibro-fatty tip, and doing with a cannula makes me feel like I'm increasing my safety rather than doing this with a needle. Just now smoothing the transition here from this supra-tip break down to the tip. Perfect.
Very nice.
So definitely see a little bit of a lift and a new bit of definition at the nose tip. Always looking for any form of discoloration or any blanching or change in skin color. So let's continue this treatment now. As we get to this point, which is 30% up the nose, we're going to start to feel some resistance, which is where the nasalis muscle is, and we need to then start to move into layer 4 of the nose. There's a bit of resistance, and we just push through. There we go. And now what I can do is start to work on this light reflex, which is giving the nose this definition. And this is where you can have this optical illusion of creating a slimmer nose by actually adding volume. And I'm making sure that my cannula goes all the way up to these lateral aesthetic lines that we have drawn on, so that we're starting to smooth these irregularities that exist in the dorsum.
And you're doing a mixture of antegrade and retrograde here?
Exactly, yeah. Generally with cannulas, I'm doing both at the same time. And I'm always moving, which I want to do with a cannula, especially in higher risk zones. I'm always moving the cannula.
You're using your non-injecting hand almost as much as you're using your injecting hand, just to stabilize the tissues, to feel what you're doing.
Precisely. Here we just get that little tip, help to create that projection. Now let's take a look. I haven't done above the dorsal hump yet, I've just focused on the lower 2/3 of the nose. How are you?
Yeah, I'm doing good, thank you. I was wanting to ask, how long does it last?
This nose filler will last about a year.
Oh, wow, okay.
Yeah. Great, so always midway, I'm just checking the perfusion of the nose. I'm happy when there's a touch of bleeding coming through my entry points. That's a good sign if you see this. Redness coming through with the gel seeping out, that's a good sign that we have perfusion. Mm-hmm. I really like how this is looking from
That's really
the side profile. I obviously need to treat this area above the dorsum. Let's continue the treatment now. I'm making another entry point. This one's just going to be a little bit sharp because I haven't done some anesthetic here, okay? 1, 2, 3. Well done. Again, I'm just going to leave this needle there for a few seconds. And then we have to again track down to layer 4 of the nose. So we feel a bit of resistance and we have to push through there. Now I'm going to be able to treat the upper third of the nose in the same way. Well done.
How high are you going here?
So I'm going up to where the upper lash line is, which demarcates where I want the start of the nose to begin. And I don't want to be any higher than that, otherwise it will start to look like the nose is starting from the forehead or the glabella, which is where we start to look unnatural.
Yeah. It's a bit of a giveaway that someone's had filler in their nose when you lose that transition point.
Yes, exactly right. Okay. So we're starting to see how we can create a lovely straight nose. This view from the top is the best view for looking at midline features like the chin or even the forehead and the nose. And I can see this light reflex straight down the middle. I can see some irregularity on this side. And I also want to create a more narrow nose. And so I'm going to do another strip down the midline to really try and bring out that definition and narrow appearance. So let's start off by, first of all, addressing this tiny little area of irregularity. And then let's create a more defined strip. So I'm starting to inject and slowly bring it down. And we'll do the same again one more time from this entry point, continuing over the top of the dorsum of the nose, over the dorsal hump, I should say. Don't inject additional volume where the projection is. So we would stop injecting here, and then we would start injecting again after the dorsal hump, bringing that all the way down. Stop there. The final job is to massage, shape, and check for cap refill. So from this view that I have here, I'm very happy with the light reflex. I'm very happy with the aesthetic lines. I'm very happy with the cap refill. From my lateral view, I can see that I've elevated the tip. I've created a new defined tip of the nose. And again, I'm happy with the capillary refill. So now let's take a look from the front. If you just lift your head off, look into the camera. Okay, slowly turn this way. And slowly turn this way. Back to the center. Happy?
Yes, I can already see it. It's great.
Great.
It's so good. It's fantastic.
Thank you.
No problem. So now let's move on to the chin. How do we want to treat the chin in this case? Well, we know that the width of the chin in a feminine chin would be the same as the intercanthal distance or the interalar distance. And so we have a good idea of how we want this tapered chin to look. And we already have a nice natural feminine chin. If you sit forwards a little, you can already see this lovely definition. But what I want to do is just create a little bit more projection inferiorly, which will really start to create that extra aesthetic impact. So I've got my boundaries here for how I want the chin, where I want the chin to live. The chin should live between these two lines. And we find the bony surface of the mandible, and we're going to be not injecting onto the front of the bone because that will create anterior projection. I don't really want that. But it's not even just on the inferior aspects of the bone, which would be just down, it's somewhere in between like this. And as we know, the filler will follow the direction of the needle. And so I want to create projection in the same direction that I'm injecting. So in this case, an injection down onto bone, aspirates projection is what I want to achieve. And this is our needle technique down onto bone. We are using a 25 gauge needle. And the reason is we want to improve the sensitivity of our aspiration. We know that aspiration is not the only way in which we can reduce safety, but it's one of our ways, and we shouldn't ever rely upon it. But if we can increase the sensitivity of our aspiration in cases where we feel like there could be heightened vascular risk, then that is a sensible and logical and rational thing to do. And so I'm injecting this down onto bone and aspirating and then creating a bolus. If I needed to, I could do another one either side of the midline, but we're going to start with the midline. Thank you. So chin up for me. And a little scratch now. Well done. Touching onto bone, nice and firm there. I'm going to aspirate. And then with my non-dominant hand, I can create a little bit of shape for where I want the filler to sit. And I'm slowly injecting.
And again, this is a nice, firm, high G' projecting product. So we're using Rev and S shape again.
Yeah. Slow injection, not only for safety, but also because I don't want the filler to start to move around. I want it to stay where I want it to go. And if you inject slowly, it's been shown that that's how you maximize that. All right, and honestly, I don't actually need to do any additional volume. This was 0.3 mils down onto the most inferior peak of the chin, the menton of the chin, to create some inferior projection and a bit of anterior projection. But if we look at this now, you can see how nice that goes with the rest of the nose, the rest of the face, to work with these feminine shapes that we're creating. All right, now we're on the final stretch, okay, which is the lips. Okay, final treatment today, we're going to talk about the lips. So, as I mentioned before, in this scenario, I'm interested in creating some height in the upper lip because I think this will create that feminine ratio that we would like to try and achieve. Like with the chin, we want the volume in the lips to exist within this interalar or intercanthal distance. And so I don't want to create much volume lateral to these landmarks. I really want to keep the volume within these lines. And we also have to appreciate that the lip is made up of compartments. And so we will have 12 anterior and 12 posterior lip compartments that we need to be respecting. And when we're injecting these lip compartments, it's always better to think about how we can fill the compartments to then give rise to these lovely superficial tubercles that are a consequence of volume that exists within those lip compartments. In terms of vascular risk, we know that generally the vessels run deep. That's one of our key concepts for the lips. And so we're mindful that our injections need to be in the subcutaneous depth. With that in mind, I'm going to be demonstrating a anterograde bolus technique to try and initially create some volume in the lip compartments. And then if that isn't enough to create the height that I want to create, I'll also look at doing some tenting techniques to create that vertical height. So let's begin. Okay, I'm going to just enter this medial compartment of the lip within the vermilion, the lip body, and I'm not just I'm deep enough so that I don't fully see the grey of my needle, but I'm still anterior to the orbicularis oris muscle. In this depth, I'm just going to let the filler do the work. So slowly injecting. My tip of my needle is here, but watch where the filler goes. It's actually going beyond the tip of my needle, and it's spreading into this entire lip compartment. Okay, so that's 0.1 mil of filler, and you can see the height that has created in that upper lip. And when I squeeze here, I can feel that sheet of filler that's spread. That filler has spread all the way to my index finger, okay, from that entry point. And here I can give it a massage, and we can actually, I'm now confident that this technique will be enough to create that vertical height that I'm after. Let's move now to a more lateral lip compartment, and we'll do the same thing. So into the lip body, and then we let the filler flow. We have to inject very slowly.
And the great thing here is we're not disrupting the compartments either.
Correct.
The chance of spread between them is much lower.
Absolutely. So look, here we are. That is 2 injections, painless injections, which is often one of the concerns our patients have with lip filler injections. Not touching the vermilion border, but you can appreciate what that's done to the top lip.
Yeah, very impressive.
Let's continue on the other side. I use the bevel of the needle facing forwards because it's more comfortable. We're just moving into the lip body here. A little deeper than this, okay? You won't get a good flow if it's this superficial. Just into this. Now, we don't actually have fat in the lips. These cushions are made out of connective tissue. So we don't have fat pads in the same way that we do in other parts of the face. We're adding hyaluronic acid into a connective tissue compartment in the lip. That's another 0.1 mils injected. And I can feel the sheet of filler between my fingers. Giving it a roll gives that some convexity. And we'll move to the lateral injection.
And this is a GEM stage 1 procedure as well. And part of that is because you're only really focusing on one thing at a time. You find your depth. Once you've got that nailed, you stay where you are, and then you can focus on your volume. You're not having to think so much about how much volume you're injecting whilst moving the needle.
Great, so very standardized here. We've got 0.1, 0.1, 0.1, and 0.1. Very happy with the upper lip now. That's starting to come together. Let's do the same in the bottom lip.
Yeah.
Okay, so remember, we're looking for a good ratio of the upper lip to the bottom lip, and if we don't treat the bottom lip, we're not going to keep that ratio. So there we are, just into that compartment. Then I'm going to flatten out and slowly let the filler do the work. Okay, beautiful. And I can feel there's the product between my fingers. That's a good centimetre of flow into that lip. And we'll do the same on this side. Remember, you won't get that flow if you're too close to the surface of the skin, but you must not be too deep behind the muscle because that's where the blood vessels are usually going to be living. So it's that intermediate depth that we're looking for in the lips.
We find that if you lift your needle up and you're lifting the lip up as a unit rather than just in the outline, it's normally a sign you've gone too deep. What can be challenging is that once you've got some product in there, you sometimes can't quite see the outline of your product, your needle as clearly.
Okay. And with that, I might leave it. I might leave it because what we've done is the most simple possible thing we can do in the lips. You'll notice there's no bleeding, there's no bruising, there's no swelling. But what we have successfully done is revolumized, targeted compartments of the lip in a very natural way. We've used 0.5 ml of filler. And from profile, from the lateral view, I can see the lip height, and from the frontal view, I'm very happy with the symmetry. The final thing we always want to do with lip filler is give it a massage using a piece of gauze, like this, to enhance the convexity and also just to make sure that there is good spread within the lips. And with that, one last look into the camera for us. So let's summarize the entire treatment that we've done for Gabriella today. Number one, we've treated the temples in the interfacial space. That's created some lift to the brows and the midface. Treated the apex of the cheek in the deepest possible depth, and also then created some lateral definition across the zygoma. At the same time, we've treated the tear trough very subtly, and we treated the lateral cheek fat, which has helped to lift along the jawline. We then moved to the nose, where we treated the columella, lifted the septal cartilages, and treated the dorsum of the nose. Then we moved to the chin for a little bit of balancing, a little bit of inferior projection right in the midline. And finally, we used an anterograde technique for the lips. This is demonstrating GEM techniques across development stages 1, 2, and 3, consistent with our principles of working from the top down, lateral to medial, and deep to superficial. How do you feel?
I feel good, thank you.
Okay. Should we get you mic'd up so we can see what you think of the photo as well? The before and after? Comes this way. Right, take a look. Turn your head. Just don't touch your face.
Okay.
What do you see?
I can't see anything. There we go. Oh, wow. Oh.
What do you notice?
I noticed my nose first of all, and it looks great. And my lips look very, it looks very natural. And the shape of my face, it seems a bit more, like less pronounced around here, a bit softer.
Natural?
Yes, very much so.
Look like yourself?
Yes. Thank you.
Daughter's not going to notice?
She might not. She might notice my nose. But yeah, I'm very happy. Thank you. Does this look symmetrical? It looks great. Thank you.
No worries. Thank you. All right. Let's have a look at that lip for you. I think with the injections, it's going to be a little swollen. This side is a little higher. It was before.
Yeah. But is there any way you can balance it?
Let me try.
Thank you.
Final additional adjustment that the patient just asked me to do was just to create a little bit of more lip height on this side compared to the other side. And I've done that just by doing some vertical threads up the lip body, being careful not to go inside the vermilion border. And in doing so, you can just create this vertical height, which I think is actually really brought out the lip. I've done this now, and if you sit forwards, you can see that that lip is actually even more defined and raised than the other. So I'm going to go back onto this side and just do a much smaller number of vertical threads, which I think really finishes off the lips nicely. Okay, give that a little massage. Now have a look in there, see if that's better.
Perfect. That's spot on. Lovely. Thank you.
No problem. All right, let's take some photos.
Yes.
And we're done. So we're back in clinic with Gabriella, who was one of our patients from the last session. And if you remember, we did a full face treatment with Gabriella, mostly focusing in the midface, treating the under eyes. We also treated the nose. I've asked Gabriella to come back. How many weeks has it been now?
About just over 2 weeks.
Over 2 weeks,
yeah.
Great. And we also did some balancing it with the lip at the end, just to get those vertical threads so that we've got equal height. So let's take a look, first of all. Well, why don't you tell us how you're feeling about everything? Obviously, you've seen yourself in the mirror plenty. So
I really
go for it.
Yeah, I love it. I do. The nose was before was a concern for me because I've had it done before, but it's never been kind of exactly how I want it. So it is perfect. And the lips as well, I really wanted them even, and it's just worked out really well. And it's not too overdone. It's like the perfect amount. And I love the fact that it all looks very natural. I think we got a little bit like in the chin as well. I forgot just the kind of thing. So it all just evens everything out nicely and just softens some of the edges. So yeah, I'm really very happy.
Good to hear it. So tell us about the recovery. How much was there in terms of pain and swelling afterwards?
So the first day or so, I mean, naturally there's a bit of swelling, but it wasn't too painful at all. Like I didn't really feel anything in my cheeks. I think my nose was a bit sensitive, and I think I bruised like a peach anyway, but there wasn't any bruising. It was just a bit sensitive for like about a week afterwards, and that's only to touch. But yeah, the first few days just a little bit tender.
Yeah.
But other than that, it was perfect. It was fine.
Amazing. So if I take a look now, if I can just turn you this way. So first of all, I really love this definition along the cheekbone. That's settled, very natural. You can't see any of the lines or the threads of filler under the skin. If you turn even more, let's have a look at that nose. So chin up a little bit. So yeah, we've still got the natural curvature to your nose, but it's so much softer. A nice projected tip as well. And we've got this chin projection that's coming all the way from the jawline, and creating a very balanced profile. So now back to the midline. Let's take a look at the lips in a bit more focus and just smile for us. Really big smile, beautiful smile, and relax. So I'm really happy with the balance of the upper lip. That was something that you mentioned, the asymmetry. So we've created that with the technique, the vertical threads in the lips. And then we did some treatment in this area to try and just create some structure, really important for treating and lifting along the jawline. And you can see just how natural and beautiful that looks. So now, final test is, you know, treatments can look good at rest, but do they look good on expression? So I'm gonna make you do some funny faces now, okay? Do that one again. We like that one, okay? Really big, the biggest smile you can, okay? And now look angry. Yeah, and now blow a kiss. Beautiful. All right, Gabriella, thank you so much.
Thank you.